So the following lecture is just an introduction to corneal disorders. We are not going to go into much of the management of some of these conditions. It is basically just to sensitize you to how to recognize some of the most common corneal diseases that we deal with. Ophthalmology is a very visual specialty. It's a surgical specialty, but we also deal with a whole host of conditions that require medical treatment, and the cornea basically straddles both of them. Some of the treatments for corneal diseases are more of a medical nature and some more surgical. So, as you all know, the cornea is avascular and transparent. It only becomes vascularized when there is some pathology present. It extends from the corneoscleral junction or the limbus to form the anterior part of the eye. It is a very strong barrier, and one is often surprised at how a structure that looks so fragile can actually be so strong. So from the outer part of the cornea, or the anterior part inwards, you first get the epithelial layer, then Bowman's layer, which is basically an area of very condensed stroma. Then you get the stromal layer. It's almost 90% of the thickness of the cornea. Over here it's a little bit the dimensions or the ratios are not 100% accurate. And then you get the Descemet's membrane, which is basically the basement membrane of the endothelium, and then on the inner part of the cornea, which separates the cornea from the aqueous humor, which sits here, you have the endothelium. And the endothelium has a very important role because the cornea can only be transparent when it is relatively dehydrated. So as soon as you have loss of your endothelium, fluid will go into your cornea and cause corneal edema and make the structure a little bit translucent or even opaque. So just again, the cornea is avascular, and because of that it needs to get its nutrients and all its metabolic needs from tears and aqueous humor. It is transparent due to the way that the stromal cells are layered. There's a minimum amount of cells, long elongated cells, and there are lack of blood vessels, and then also, as I said, the endothelial pump that pumps fluid from the stroma into the aqueous humor keeps the cornea relatively dehydrated versus the aqueous humor. Then the diameter or the size of the cornea is about 10 millimeters at birth, and on average about 10 millimeters in diameter in adults. And then the normal central corneal thickness, it varies a little bit between different ethnic groups, but the normal central thickness is 540 to 550 micrometers. So to examine the eye, for corneal diseases, there are many ways that you can do that. The first instrument you would use would just be a pen light. Often we nowadays don't have pen lights available. The reps used to give them out, but not anymore. So we often use our cell phone lights, which actually works very well to examine the eye just like a pen light. Then fluorescein and cobalt blue light. So fluorescein is an orange substance that when it's inserted onto the ocular surface, it will stain any damaged epithelium of the cornea. So we just remember we call green light with the ophthalmoscope, we call it red free, and we call the blue light of the direct ophthalmoscope the cobalt blue light. That is something that we'll talk about more when you do your rotation with us. Then with the slit lamp or the biomicroscope, we can see the cornea in great anatomical detail. This is how one would see it on a relatively low magnification. So if you put it on a really high magnification with the slit lamp, one can very clearly see the different layers of the cornea, and that helps us to determine, we as ophthalmologists, it helps us to determine on which layer or what level pathology is present. So here's just another picture of the slit lamp, and we would usually do slit lamp examination in a darkened room, just here to show how it is used. Then keratometry can be done in various ways. It can be done manually, but it's very labor intensive. Nowadays there are luckily keratometry devices that does it automatically and gives you a readout of the corneal curvature. In this instance, the radius is expressed in millimeters. So the radius of this cornea in the one axis is 7.70 millimeters, and in the radius in the 90 degrees to that is 7.55 millimeters. Now these can also be expressed in diopters, which shows the refractive power of the cornea, and the refractive power of the cornea is around about 42 diopters. Then pachymetry, just it's not something that you would do as a general practitioner, but it's good to know the term. And pachymetry just basically means the thickness, the measurement of the thickness of the cornea. And you can see in this case the corneal thickness is 546 micrometers, which is normal. Corneal topography, again, there are various ways, manually or with modern machines, that one can look at the corneal topography. It basically just shows us whether the surface of the cornea is nice and round and normal, or whether there are protrusions or depressions in the cornea, and it helps us in various diseases, especially ectasias, or diseases where there are thinning of the cornea. So I'm just going to show you a few pictures of drops and instruments that are really your friend when it comes to examining the cornea. First of all, Novacin or oxybuprocaine. When you see this bottle, this yellow bottle, it doesn't matter what language it's in, Novacin with a yellow top is your topical anesthesia drop, and it really makes a huge difference in patients when there's something that is irritating the eye, or the surface of the eye is painful, and you want to examine the eye properly. You often need to anesthetize the surface of the eye, and this is how we do it. So you put in a drop of Novacin. The next thing that we almost always do when we examine the cornea is to put in drops of fluorescein. So fluorescein is an orange substance, but when you shine the cobalt blue light on it, it fluoresces in a green kind of fluorescent pattern or color. So fluorescein minims are these single-use drops, but the most cost-effective way, if you can get hold of these, to put fluorescein in the eye is by putting in a drop of fluorescein on the surface of the eye, and then you put a drop of Novacin on the surface of the eye, put a drop on the fluorescein strip, and then you just touch lightly on the surface of the eye. Then the fluorescein will go onto the surface of the eye. And then lastly, your ophthalmoscope. When you buy an ophthalmoscope set or ophthalmoscope otoscope combination set, then please make sure that you buy good quality equipment with a rechargeable battery. The ones that use non-rechargeable batteries always have a lower light intensity, and then you get models that do not have the cobalt blue light. In this instance, your red-free light will be activated by pushing this button over there, and your cobalt blue light will be activated when you turn this dial to the cobalt blue filter. And this is just basically what it looks like when it shines into a person's eye. So one of the most dangerous conditions for the cornea and for the eye is infective keratitis, and the reason for that is if it's left untreated, it can often lead to perforation of the eye and of the cornea. Once that happens, you can get infection that spreads to the entire eye, giving you an endophthalmitis. And the most dangerous ones are the bacterial keratitis, corneal ulcers, and fungal keratitis. Viral keratitis can also be superinfected by either these two. So bacterial keratitis is relatively uncommon, and it's very uncommon in healthy eyes. So when you see bacterial keratitis, you must actually look for a reason why a patient would have bacterial keratitis. You ask about contact lens wear, which could trigger you to think of a pathogen like Pseudomonas. Often there's trauma, especially corneal abrasions, any other ocular surface disease like dry eye, and sometimes lid disease. So some lid diseases will cause scratching or chronic scratching on the cornea and make the corneal surface more susceptible to infection. Then the signs to get: firstly, an epithelial defect. I'll show you a picture of it soon, and then you can get stromal infiltrates, which is just basically almost always comes up as a white discoloration of the central cornea. Hypopyon, which is pus in the anterior chamber, so it will always collect at the bottom of the anterior chamber. And then perforation. So usually perforation is preceded by clinical thinning of the cornea. But if a patient has a very severe keratitis, or if the patient took too long to present to ophthalmology, then perforation could happen even before you see the patient, and that then causes the anterior chamber to fall flat and sets about a very dangerous set of events for the eye. So here we can see the fluorescein on the margins. You can see the area of healthy cornea there where there's no staining, and then where there is the corneal ulcer or the infective keratitis, you can see that that area stains with the fluorescein. You just again, stromal infiltrators, whitening of the stromal area of the eye, and usually with a bit of thickening. Here we have a severe bacterial keratitis. One can already see some thinning on the edges over here with again a stromal infiltrate or stromal abscess almost, and then hypopion. So hypopion is pus in the anterior chamber, and remember, hyphema is blood in the anterior chamber. They look exactly the same except the color is different, of course. Then here's just another picture of bacterial keratitis, and in this case a patient has bacterial keratitis and endophthalmitis, so the infection has spread right through the cornea and infected the entire globe. And this is a very dangerous condition for the eye, because it means that there's an abscess in the vitreous cavity of the eye, which is very difficult to manage, whether medically or surgically. Then viral keratitis, as we said before, can be quite easily managed if it's picked up early enough, but if it's left untreated, it can grow into a large viral keratitis, which can get secondarily infected by bacteria or fungi, and then you have a big problem. So herpes simplex keratitis forms a very, very, very typical dendritic ulcer, which can later grow into a geographic ulcer that almost looks like a map on an atlas. And just know that these patients have a very irritated or sometimes painful ocular surface, but when you touch with the wisp of a cotton bud onto the affected eye, you will recognize that the affected eye corneal sensation or the surface sensation is diminished. Just remember, whenever you test the corneal sensation, you basically just take a cotton bud and just thin out the fibers of it and touch lightly on the corneal surface. Always touch on the normal eye first, because the last thing you want to do is to take infection from the affected eye and transplant it onto the non-affected eye. So here are a few pictures of the dendritic ulcer. Very, very distinct picture. If somebody wakes you up at 3 o'clock in the night and shows you this picture, it's only one thing that looks like it. Herpes simplex keratitis, herpes simplex keratitis, herpes simplex keratitis. And this there's another staining method we can use, which is rose bengal. Just incredibly expensive, so we don't usually have it in stock. Also very difficult to get hold of. And then, as you can see in this picture, you have the dendritic ulcer. But if it's left to grow unchecked, if the patient hasn't been treated with topical Zovirax, what will happen is that these dendrites will eventually thicken and cause something that looks like a continent or an island, and that is why it's called geographic ulcer. So this is just the latest stage of dendritic ulcer, of herpes simplex keratitis. The other way in which herpes simplex keratitis can present is with disciform keratitis. All that it means is that the endothelium of the cornea is damaged due to the virus, and then there's an infective component, but primarily a inflammatory component that then causes damage to the endothelium. And remember, when the endothelium is not working properly, the water cannot be pumped into the anterior chamber, the cornea cannot be dehydrated, and the cornea swells up. So what you see here is then a central zone of stromal and a little bit of epithelial corneal edema, but mostly stromal edema. When you look at just with a pen light or with full illumination with your slit lamp, you can see this area there that looks swollen up almost like a disc. That's obviously where the name comes from, disciform keratitis. If you look right at the back there, you can see a relatively typical picture of how the endothelium looks. It's swollen up and crinkly and unhealthy. And then when you shine your light with a slit beam, with your slit lamp by a microscope, you can see that there is the normal thin or normal clear cornea, but there's the endothelium, the back of the cornea, and here you can see the thickened stroma, or the disc of the disciform keratitis. So here the primary treatment of this is steroids, but I always like to just treat it with a background, or just treat it together with Zovirex ointment, even though in a lower dosage, more a preventive dosage of only 3 times a day. So herpes zoster can present in the eye in very different ways. It mostly, we see herpes zoster on the skin. Patients can have anterior uveitis, they can have conjunctivitis, and especially if they have herpes zoster ophthalmicus, that affects the side of the nose. In other words, the skin lesions are not only on the face, but also on the side of the nose. Then you have a higher chance of having the eye or the globe affected, either by conjunctivitis, keratitis, anterior uveitis. So herpes zoster keratitis looks a little bit more benign than your herpes simplex keratitis. In this case, they look like almost dendrites, so we call them pseudo dendrites, and they're also treated with Zovirex. And it's rare that you would have this alone without the skin disease. So most of these patients will be treated with topical and systemic acyclovir. We can see these dendrites, they are not as well formed as the as with hyperherpes simplex keratitis, so pseudodendrites or microdendrites. Then fungal keratitis is very dangerous for several reasons, but one of the reasons are that they are difficult to diagnose. So when we do a scraping of a bacterial ulcer, there is not a great chance, but a significant chance that we will be able to identify the causing pathogen. And fungal keratitis can look very, very similar to bacterial keratitis, but we do send samples for fungal growth as well, but obviously it takes much longer to diagnose. And often when we treat a bacterial ulcer and we are just not winning, then we think that it may be a fungal keratitis that mimicked a bacterial keratitis. Although there are a few things that are different to the typical fungal keratitis, and I'll name them for you now. First of all, in the history, if you have somebody who was who tells you that they were scraped on the eye with a piece of wood when they were chopping wood, maybe a thorn went into the eye, or any vegetable matter that traumatized the anterior cornea, that's a big warning sign that you may be dealing with fungal keratitis. Then any chronic ocular surface disease, diabetes, or immunosuppressed patients, they are all more likely, well, have a higher risk of getting a fungal keratitis. So there's a picture that I'll show soon, but just look out for this following, that the borders of the typical bacterial keratitis are more distinct, while the fungal keratitis can have almost like a feathery kind of indistinct border, and while bacterial keratitis almost always only has one lesion, fungal keratitis can have satellite lesions. So there's one primary lesion and then a few smaller lesions away from the original fungal keratitis. They are very, very difficult to treat and also to diagnose. So often we need to take a sample in theatre where we either scrape, do a deep scraping of the corneal ulcer, put it on a microscope plate, or we physically cut out a biopsy. There are other pathogens that almost always only get diagnosed with a biopsy, but we're not going to go into all those details. So, as I mentioned before, here's the primary lesion with these borders that are quite indistinct, call them feathery borders. And then when you look further away from the primary lesion, you see these satellite lesions of fungal keratitis. We always treat these with topical antifungals, natamycin, and then also with systemic antifungals, and treatment can last for up to 3 months or more, and sometimes if nothing works, then we have to do a corneal transplant to remove the entire focus of infection and replace it with a donor cornea. That's a keratoconus. This is all of these diseases are quite rare, but as corneal diseases go, keratoconus is relatively it's a condition that we see a few times a year. It's one of the ectasias, and the ectasia just means that there's a part of the cornea, or a region of the cornea, where the entire cornea is thinned. It's basically the stroma that thins, and these conditions can all lead to progressive loss of vision, but they can also have more sinister side effects, especially when the endothelium gets broken due to this deformation of the cornea, and then you can get fluid. As you can guess by now, when the endothelium is damaged, you can get fluid that goes into the eye, and then we call it eye drops, or severe corneal edema. And this is a way that some of these patients present for the first time. So let's just retrace a little bit. Keratoconus is a progressive disorder, falls under the corneal ectasias, where the cornea assumes a conical shape secondary to stromal thinning. Like I said, stroma is thin, and that then deforms the cornea. So you almost never see it in younger children, but the onset is at puberty, with the following, where the corneal surface, instead of being nice and round, it has a more conical shape, almost like a sharper edge, and you can see it very nicely when the patient looks down. So when you look at the red reflex, that is one of the techniques that we will teach you. It's where you look, where you put your ophthalmoscope on the +2 setting with a normal white light. +2 just means that you are adding 2 diopter to the strength of the eye, and then you look from a distance of about 40 centimeters at the eye, and then you see what the reflex looks like, what you get back. It usually has this reddish orange color, and it must be uniform. But when you see anything abnormal in that reflex, then it alerts you to the fact that there's a problem. And then when you then do your slit lamp by microscopy, or do fundoscopy with your direct ophthalmoscope, you can zone in onto the actual pathology. But in keratoconus, you get a typical oil droplet reflex, and I'll show a picture of that. Next thing is the Munson sign. We've actually already seen it on the previous picture, that when the patient looks down, you can see that the lid gets pushed away a little bit in that conical shape. They get very poor vision due to irregular astigmatism. So think back a little bit to the refractive error lecture, and they have a steep corneal curvature, so they will have abnormal corneal topography. Like think back to the so the corneal topography is not something that you will ever use yourself if you're not an ophthalmologist, but it's good to know these terms so that you know what we are talking about. So over here you will see that there's a red reflex that is not normal, and the reason why we're saying that is that it's not completely uniform. So some of the red reflex it's normal in that part, but then when you go lower down, it gives you almost an idea that there's an oil droplet on the inside of the eye. There, just again, the ectasia. This is Munson sign, but here's another picture of Munson sign. Munson sign is just this abnormal steep curvature of the eye, which should have been round like this. And when you look there, there's a little bit of an opacity there, which could be eye drops or a scar on the cornea, secondary to corneal eye drops. So just the management of these, management of these conditions have progressed quite a bit over the years. There's now another treatment modality that's actually not in this list over here, called corneal cross-linking, where a substance gets dropped onto the eye. You wait for it to infiltrate the cornea, and then a laser beam gets shone onto the eye in over the cornea, and that then basically strengthens the weak cornea, and it can, if it doesn't cure it, none of these things are totally curable, but they are manageable. And corneal cross-linking, if you get a patient early enough, you can significantly extend their the span of their good vision. But more simple methods are first spectacles, just to correct the usually astigmatism that they get. It's a little bit more of an irregular astigmatism, which means that it's more difficult to deal with than regular astigmatism, where there's just two axes 90 degrees to each other. In this with irregular astigmatism, you can have multiple axes, making correction of that very difficult. You can also use rigid contact lenses. The beauty of these are that they actually give you almost like a new anterior corneal surface, which is nice and rounded, and it also supports the cornea at the back to a certain extent, and also can also prolong the time that it takes for this condition to progress. And then with a lot of corneal diseases, once you get to a point where there's nothing else that you can do, and the eye either gets perforated or there's a corneal scar secondary to eye drops or infection, then we can do a corneal transplant. So corneal transplant is actually a very elegant procedure. We usually use interrupted sutures. You can also use uninterrupted sutures, but you can sometimes go right round, and when you make your suture, if there's a problem with your instruments and the suture breaks, you've got a big problem. You have to do the whole thing all over. The other beauty of these are when one suture gets loose or it's too tight, that the corneal surface has an abnormal curvature in one position. We can sometimes either remove sutures to flatten the cornea in some area, almost like a T-cut, have that effect with refractive surgery, or if a suture becomes infected or loose, we can just remove the one single suture and replace it. So if you had a continuous suture and you get suture infection, then you would have to remove the entire suture, and if the cornea hasn't healed sufficiently, you have to do the whole procedure all over again. So now corneal trauma will be discussed in your trauma lectures later again, but just a few common things that we see, and it's not a bad idea to sensitize you to those already. First of all, corneal foreign body. Usually it's a piece of metal, very often from somebody who's done grinding and didn't wear a proper spectacle correction. Sometimes in a workshop, somebody's doing grinding, and then the piece of grinding particle, grounded off particle, gets airborne and gets into somebody else's eye in a workshop. So there are definite safety protocols that also always has to be followed when somebody is using a grinder. Mostly it is metallic foreign bodies, and by the time you see the patient, it always looks rusted, and it often has a little rust ring around it, almost like a little crater. So you can, of course, also, we've seen patients with thorns stuck, broken off piece of thorn stuck in the cornea. Remember, the cornea is actually a very, very strong structure, so it is possible for a thorn to penetrate into the cornea, and once somebody breaks off the thorn, a piece of the thorn can break off and stay in the cornea. And then obviously in the likes of motor accidents or so, you can also get some fine glass particles. As an intern, I used to remove them myself. We just used a stereoscopic magnifier. So you must have some kind of a plan of how you can deal with these corneal foreign bodies if you don't have a slit lamp to your disposal. So try and get something that can give you some magnification. Somebody must hold a light for you when you want to remove these. And of course, our friend with the yellow top, the local anesthesia, oxybuprocaine, that is the you first put the local anesthetic in. Immediately the patient will feel tremendous relief, and then you use a 18 gauge needle, which is the green needle, or any needle that is thicker than that. So these thick orange, red needles, and all those grey thick needles, but not a thinner needle like a blue needle, or those thin brown needles. Any needle from a green 18 gauge upwards, and then you can just with a bevel up, just gently scrape from the top, and then once the metallic foreign body is off, you'll see that rustring remaining. So this is something that we can, as ophthalmologists, we can use a specific type of micro grinder that actually called a corneal burr, that removes these, and then, but you can also sometimes remove them with a needle in about a week after the initial incident. Or sometimes the rustring disappears with time, but whether or not the metallic foreign body was removed successfully without any additional trauma, very often they leave tiny little scars. So if you have a central corneal foreign body, they can actually cause long-term visual disturbance. And then, of course, whenever you've scraped the cornea or damaged the epithelial surface, your stroma is exposed and your eye is in danger of getting infected. So always use antibiotic ointment after removing a corneal foreign body, and you can just close it with an iPad. When the patient gets home, they must actually take the iPad off, because you don't want any organism to proliferate in that like tropical condition that you've made with a patch. And then we would usually follow them up in a week's time just to check that there's no secondary infection, and the rustring can be removed with a needle. So I used to remove them as an intern as well after a week. But if you're not comfortable with removing these things, rather refer them as an urgent referral to ophthalmology. It's something that we can deal with very quickly. Then corneal abrasions, here usually it's something that's scraped on the eye. My wife got a corneal abrasion when she was playing with the dog, and the dog's nail scraped her cornea. What it usually does is it gives a very large surface erosion, which presents then with pain, again photophobia or light sensitivity, blepharospasm, which is tight closing of the involuntary, basically closing of the eyelids, and injection. So injection, as you've probably heard before, is what ophthalmologists use to describe redness of the eye. So injection can either be circumcorneal or just around the cornea, or it can be generalized, which is when it affects the entire conjunctiva. So just remember, corneal abrasion will give you a large erosion or a large epithelial defect that you can see with fluorescein staining. So this is what it looks like. There's the normal cornea around. You've put in your Novacine, you've put in your fluorescein, and you've looked at the eye with your cobalt blue light. In this patient, who's had a trauma history of something scraping on the eye, and that is what you expect. You'll always see that the surface in a corneal abrasion is nice and clean, and you don't have corneal infiltrates like you have with the infective keratitis patients. Just again, your history of the scraping injury, pain and photophobia, conjunctival injection. This is what we call general injection. Then we color it with fluorescein dye. With corneal abrasion, there's an epithelial defect, but no penetration into the cornea. Just remember, if you ever put in fluorescein and you see an area that is lighting up, and a piece of and little dark drops of aqueous fluid drips through the cornea, then one must know there's perforation. So corneal abrasion has no perforation, but just always look for any leakage in any patient with corneal trauma. Then we would give this patient antibiotic ointment it's basically prophylactic to prevent this from getting secondarily infected. Remember what I said, that there's always a reason why people get bacterial keratitis, and corneal abrasion is one of those. It's very uncomfortable, so you want to give the patient painkillers, and what also helps is to close the eyelids so that the eyelid doesn't continuously scrape, or the margin of the eyelid doesn't continuously scrape on this lesion. Sometimes you can put in a contact lens. That is something that we would use, but don't do that until the patient has been seen by an ophthalmologist. And then Mediatics, these are just drops like cyclopentolate or atropine, belladonna alkaloids, basically that can they will let the pupil dilate, but they will also relax the ciliary muscle. So you will take away the patient's ability to accommodate. Think back again to the refractive error lecture. And as a result, when the ciliary body is relaxed, the ciliary muscle is relaxed, the eye becomes immediately way more comfortable. The photophobia basically goes away completely, because that is where the photophobia comes from, painful contraction of the ciliary muscle. So just to summarize, diagnose it with all these methods. Just put antibiotic ointment like chloramphenicol drops on 3 times a day, painkillers, and some Mediatic like atropine or cyclopentolate. Then a very common thing is arc eyes or ultraviolet superficial keratitis, which is the more descriptive correct name. This is caused by ultraviolet exposure, excessive ultraviolet exposure, which you can get from welding or severe reflective or reflected sun exposure. So if people have been at the beach all day, or on and sometimes especially going sailing or something without wearing sunglasses, they, people can get ultraviolet superficial keratitis, but it's by far the most common reason in our country is unprotected welding, either by the person itself or somebody maybe helping the welder. In the more northern parts of the world, where there's a lot of sun reflecting off the snow, they are also more prone to get UV superficial keratitis. So you often hear from a friend who's gone skiing, and then they just developed an extremely painful red eye. So the ultraviolet rays cause epithelial damage and exposure of the nerve endings. So the cornea probably has the highest density of nerve endings in the entire body, and so if something if the nerve ends get exposed, then the eye becomes very painful and photophobic. This is just basically how it looks like. It looks almost normal, but sometimes you can get tiny UV-induced microerosions. Then we usually have ciliary injection or circumcorneal injection, where the redness is just around the cornea. The moment you put in Novocin, this patient will feel relief immediately. They will sometimes beg you to give them fluorescein to use at home. We can never do that because it actually impedes healing of the cornea. But we have had instances where patients have got seen another yellow bottle of Novocin lying around and taken it home with them. So corneal laceration, it's exactly what it says. This, like all of these, like a chemical burn and any trauma that you can't deal with yourself, you have to refer them as an emergency to ophthalmology. You must just be very, very careful to not force eyelids open or cause anything that makes the patient squeeze the eye too much, because what you don't want is, when the cornea has a laceration, you don't want the ocular contents to be pushed outwards. These patients need surgery as soon as it is feasible, and the surgical results can often be quite remarkable if you see what the eye looked like before and after, and also the visual acuity or vision can be either restored or improved greatly after the surgery. So here's just a corneal laceration. This is what we call a limbus to limbus. The limbus, or the edge of the cornea, is sitting here, and the other one there, so it's right through limbus to limbus. You can get the uvea, which includes the iris, to prolapse through the wound. So during surgery, this must first be pushed back. They often develop a traumatic cataract, like you can see there, that whiteness, the lens has become opaque. So we often, when we suture the corneal laceration, we often have to remove the cataract at the same time if the lens also got damaged, and sometimes we have to repair the iris as well. Right, so chemical burns are one of the most urgent and acute trauma to the eye that you can deal with. And so when a patient comes into a trauma unit with a chemical burn, you must immediately let the patient lie down on the bed, put some Novocin on the surface of the eye, and then rinse out the eye with copious amounts of normal saline, even water or ringers, whatever you have available, whatever electrolyte kind of fluid that you have available. And then the other thing is that there's often pieces or particles of either cement or firecracker or whatever caused the corneal chemical burn to the eye. So You have to evert the eyelid. We'll teach you that technique, how to evert the upper eyelid. The lower lid, it's usually much easier to examine because you just pull the lid away from the eyeball. But it's very, very important that after you've rinsed out this eye or even while changing the bags, say you've running 1 liter, now you want to wash out some more, you can take that time to put in a little bit more Novacin, use a cotton bud, and just wipe the inside of the we basically call it the fornix, but where the palpebral conj and the bulbar conjunctiva gets together in that gutter there. Just wipe it out with a wet cotton bud in the inferior fornix as well as in the superior fornix. And then one can send this patient for further intensive management by ophthalmology. And just remember, if you're far away from the center where there's an ophthalmologist available, and you are not winning by either examining the eye or rinsing it out in a child, it may even be necessary to take the child to theatre to do the rinsing there and to remove the residue under the eyelids. So typically patients who have chemical burns with cement or with firecrackers have these debris sitting hidden in the fornices of the eye that you can't see if you don't evert the eyelids. Just one last thing here is that alkaline burns or alkaline substances can necrotize the stroma of the cornea, and it can actually spread very rapidly deeper and deeper into the cornea, and there's a much higher risk of perforating the cornea than you would have in an acid burn, because what an acid does is when it hits the cornea, it actually coagulates the proteins and almost causes a barrier against further burning. So here's a person with a chemical burn. There are many ways to classify it, and that's not something that you need to know, but you can go and read up on it. But basically what we look at is what is the size of the corneal burn wound. Does it extend beyond the limbus? So here you see the corneal limbus, or the edge of the cornea, and once these burns go across the limbus, they damage the limbal stem cells that are located around the cornea. And then because the limbal stem cells produce epithelium, which must cover this defect, when you've lost limbal stem cells, your healing is much slower. But these are all things that must be left up to the ophthalmologist to deal with. So, right, it was quite a long lecture, but it is on YouTube, so you can go and watch it again. We basically just scraped the surface of corneal diseases, if you'll excuse the pun. But just remember these pictures and try and when you are at your ophthalmology rotation, you must at least once or twice put the Novacin and the fluorescein in, so that when it comes to a time where you are the primary caregiver, or the first doctor that the patient sees, that you know how to deal with it, or that you have the means to deal with it. All right. Good luck for the rest of the week's lectures. Bye.